Good afternoon, everyone. My name is Garrett Schmidt. I'm the Managing Director for Value-Based Care Exhibit Hall, or VBC Exhibit Hall. I'd like to welcome you all to today's webinar hosted by Stellar Health. It's called How to Successfully Engage ACOs and Affiliate Networks to Unleash Economic Value. And I'm really excited to hear from our speakers today, and I'll introduce them in just a moment. A few items of note before we get started. Just like usual, everyone's joined in listen-only mode, so you don't have to worry about muting yourself or your microphone. That's been done for you. Also, I'd like to let you all know that the webinar is being recorded. And so what I'm going to do is after we're done here, later on this afternoon, or maybe even as late as this evening, I'm going to send everyone who's registered a link to the recording. And also that there will be a link to where you can download the slides from today's presentation. So I'll be sending that to you afterwards. And that's even for those who weren't able to attend today. And then finally, we really want to hear from you during the session today. We want this to be somewhat interactive, and at the very end, we're going to have a Q&A, but you don't have to wait until the Q&A in order to ask your question. So if at any point you have a question, go ahead and ask it through the module that you have there. There's a little question area, not the chat, but there's a little question area specifically for that. And then we'll get to as many of those as we can today. If for some reason we are not able to get to all the questions, which happens occasionally, then we will make sure to get back to you via email afterwards. So definitely please ask your questions. We want to hear from you. Finally, without further ado, I wanted to introduce our presenters today. We have Daniel Lithwick, who's the Director of Customer Strategy and Development with Stellar Health. And we also have Dr. John Schott, who is the Medical Director for St. Luke's Health Partners. And so we're really excited to have these guys, and they'll be giving a little bit more thorough explanation of their background and introduction. So I believe Dr. Schott is going to kick us off, so I'll hand it over to you at this time. Welcome, guys.
Thanks, Garrett, and thank you all for joining. I'm John Schott. I'm a family physician. I was born and raised here in this part of the country. I worked clinically for about 17 years in Eastern Oregon in a small town. During that period of time, I was exposed to a lot of the clinical transformation work that was occurring in Oregon. A lot of that was prior to Oregon doing its Oregon experiment with Medicaid and value-based care. I had the opportunity in 2016 to join St. Luke's Health Partners, and so I came here then. And a lot of my work is trying to figure out how we change the business model in a way that really supports what has to be done on the clinic side to make value-based care work. And Garrett, or Daniel, I'll pass it to you.
Yeah, thanks, Dr. Schott, and thanks everyone for coming today. Happy we have a pretty good audience here. So Daniel Lithwick, I'm Director of Customer Strategy and Development at Stellar Health, which we'll tell you a bit more about later in the presentation. My background is really initially more focused on clinical research and operations and evidence-based medicine, operating out of a health system in Canada, actually. And learned a lot about care delivery and more focused on the patient experience and again generating evidence-based medicine for like clinical knowledge translation activities. But what I found over that time working in the health system was I really wanted to focus more of my time and effort in healthcare technology and innovation directly as it pertains to innovating in the care delivery space. So I actually moved to the States, where I've been working more in an entrepreneurial role focused on health technology and value-based care reimbursement strategies for the last 5 years, and I've been with the Stellar Health team pretty much since its founding here, and really excited about what we're doing, specifically excited about our partnership with St. Luke's Health Partners. We'll get more into that during the presentation. I'm going to go to the next slide here. Before we start the presentation, we're going to have a couple poll questions here just to maybe level set and get a bit of a better understanding of our audience. So, whoops. I think the poll is open now. Garrett's running this. If you wouldn't mind just answering, which best represents the organization that you work at. I believe you can select multiple, but obviously helpful to see if it's which one of these 5 best represents you in the audience today.
Hey guys, this is Garrett. I'm just coming in for a second. We'll give this about another, people are putting in their answers. We'll give them about another 5 seconds here. And Looks like, okay, looks like most of the answers have come in. So I'm going to close this out. And would you like me to put up the answers?
Yeah, I think that'd be good.
Okay. There we go. Are you able to see that?
No, I think it's because I am the
Okay, well, I'll go ahead and read it out. At ACO, we have 26%. CINs are 19%. Payers is 7%, and this is of our audience here today. Vendor organizations are about 26%, and other is 22%.
All right, even spread, great. Well, this one is probably pertaining more to those that fit into our, I think it's 33% at the top there, but so if you're an ACO or SIN, per our topic today and some of the things we're going to be talking about, how much of your network makeup is based on affiliate providers? So those that, terminology might be voluntary, but ultimately not employed by the parent organization. And as opposed to like MPIs or tax identification numbers practices, value-based lives is the metric, roughly we like to go by here.
Okay. We'll give this just a moment here. Got another 5 seconds here. I'm going to put in your vote. Okay, looks like pretty much everyone has responded. So I'm going to go ahead and close this out, and then I will read the answers to you guys, since I know that as presenters, you're not able to see it very well.
Yeah, thank you.
Okay, so here are the results. We have less than 25 is about 30% of the audience. More than 25, greater than 25 is 10%. Greater than 50% is 40% of the audience. And then more than 75% is 20% of the audience. So it looks like the majority of folks are in the more than 50% range.
Super helpful. Yeah, I think just hopefully others learned about the other attendees as part of that exercise. And what I'll say, we have several, Stellar Health has several health system, clinically integrated network and ACO partnerships. And that C bucket there between 50 and 75% is where we typically see, even in, economic centers like New York City, for example, large urban areas. There's still, with large hospitals, it's quite a bit of an affiliated network, comprises how patients are cared for. So pretty consistent with what we see in that C bucket. And I believe Dr. Schott, St. Luke's Health Partners, from a, managed care lives perspective, also falls into kind of that C bucket there. But yeah, just helpful to know. And I'm going to pass to Dr. Schott now to just give a bit of a background on St. Luke's and some of the great work they're doing with their clinically integrated network, population health, and value-based care delivery.
Thanks, Daniel. So I think really I've got it pretty easy. My job in this section is to just give you some background about St. Luke's as a health system, and really to differentiate St. Luke's Health Partners from the health system, because that's a key distinction. The health system has been here quite a while, over 100 years, serving the Boise area. We've got a strong reputation in terms of quality. We have 8 hospitals in the only children's hospital in Idaho. I think we currently are still the largest private employer in the state, which is close to 16,000 employees. And it's obviously a growing area. You can go to the next slide. The market that we share is interesting. We enjoy having a strong reputation. We're pretty much the market choice for healthcare. There are 2 other health systems in the area, but overall we have the market share. We have another distinction, just being geographically located where we're at, with quite some distance from any other metropolitan area. I think from my perspective as a clinician, that kind of allows us to act a little bit as a petri dish. We can do some things that probably are a little bit more difficult to do in other markets. The other thing that's interesting is that I think we have over 50 plans in the MA space. in this relatively small area. So from a payer perspective, it's very competitive. But we're locally owned. The health system is a nonprofit entity. The other thing about it, though, is I think that because of all of these things, in many ways, we're primed for a disruptor to come into the market. I think the health system leadership recognized this quite some time ago, and I think that drove some of the decisions that were made to really start St. Luke's Health Partners. You can go to the next slide, Daniel. This strategy slide is the health system strategy. When I look at it, I think that most organizations capture a lot of the content here because all of it is relevant probably wherever we work. Community health, population health, I think everybody agrees that that really is the future and the challenge for the work that we have, talking about quality and access and affordability and value. Everybody's doing that. I think the question for the health system was what action were we going to take to actually deliver on that? And that gets us to Health Partners. You can take the next slide, Daniel. So Health Partners actually has been around in some form for close to 10 years. We were a pioneer ACO close to 2010. We're a low-cost center. And because of our quality, the ACO performance specific to that population has always been strong. In 2017, we branched out at that time, working with, I think, 6 or 7 different payers. Since then, we've grown, currently working with 11 payers. The map that you see here represents the majority of the network and really the focused effort of the work that we do. VCO is a term that the state employed to apply to Medicaid, the Medicaid population and organizations that contract with the state of Idaho around value-based arrangements for Medicaid. Our VCO is the largest in the state, and our providers actually extend beyond that colored section that you see on the map. So within the VCO, we have providers spread throughout the state. The 250,000 lives is significant. From a health system perspective, when you account for uninsured lives that we care for, that's over half of our business as a health system. So over 50% is at risk, and that's significant also for a health system our size. One thing that we think is pretty unique is the one uniform interim payments structure that applies both to our facilities and our providers. That's been really important. Again, if you think about it from a health system perspective, we had to negotiate that with our health system facilities, and having that leadership really give that vote of confidence to the network was important. But that uniform payment structure really levels the playing field across the network. We are small. I think our numbers are closer to 80 team members here at SLHP currently. The majority of that team is comprised of care management, with over 40 care managers currently that are part of the network. You can go to the next slide, Daniel. This slide really is intended to share how we interact both with payers and our providers. So we have a single signature authority on behalf of the network, both facilities and providers. We use that to negotiate with payers, and I'm not a business guy, but I think of it kind of like a high stakes poker game where we look at the historical spend and illness burden within a population and basically sign arrangements with payers around those populations to take that full accountability. Those facilities and payers interact with the providers interact with the payers just like they usually do. So they drop the bills, charges occur just like they normally would. We can influence how care is delivered by using things like our care management resources, helping our providers develop clinical pathways. We also have a funds flow measure, process. That process includes core measures. Those core measures have been consistent over the last 6 years, partly because we want our providers to really be able to focus and change clinic operations in a way that are sustainable. The challenge here is that because of the nature of our funds flow, our currently we're in the process of reconciling funds flow for last year. So it's about an 18-month leg at best, which means going into this, we saw pretty quickly that being able to financially incentivize and support the work that's being done within clinics wasn't optimal. Trying to figure out how we bridge that gap was important for us. You can go to the next slide, Daniel. The other challenge, I think, for all of us is always data. How we not just share data, but give information that can be acted on at the point of care. These three areas are the three areas that we've tried to really focus on with our providers. The first one is obviously knowing the population. It's important for us at the network that people, our providers know the people that they're accountable for. I think optimally in primary care clinics, there should be a process of panel management. You know, accessibility, especially coming out of the pandemic, has been more of an issue than it has ever been. But unless providers and clinics are looking at their panels, it's really hard to develop scheduling templates that reflect accurate access. Within that, we've also asked our providers to focus on annual wellness visits. And this was a strategy we took 3 or 4 years ago. As a provider, when CMS rolled out their annual wellness visit template, it was pretty hard for me to buy into that. It was pretty much a point and click. What we've tried to incorporate is something that's more comprehensive. So it's something more like a comprehensive annual wellness visit, where really care gaps are identified and the complete clinical picture of that patient is something that providers and care teams look at, so that as those issues are assessed within the clinic, they're documented and care plans are developed to support the needs of that individual patient. That gets back to data. How do we share that data that really drives that care? And that was another challenge for us that I think Daniel's going to speak to. What we have driven for consistently is 4-star performance within our MA plans. 4 to 4.5 stars is really where we think the optimal range is. 5 stars, we're not sure that the effort and the financial benefit is really there for that. So we've been able to maintain that 4-star performance consistently. Our ACO, as I said earlier, has really been a top performing line of business for us. What we've seen, though, is that if we can get providers tied into this work where they know their population, they're getting their patients in for the annual wellness visit. There's a direct correlation to what happens in terms of both emergency room utilization and admissions. We have a pretty robust post-acute care program that has managed our SNF days as well. The challenge, though, again, is as we build these business arrangements, how do we clinically help providers, give them the information they need, and support the work that's being done in the clinics so that it's something sustainable? And I think those two key areas are really what drove us to look and to begin to work with Stellar. And it's been a great partnership so far. I'll let Daniel take it from here to get into more of the nitty-gritty.
Excellent. Thanks, Dr. Schott. That was a great background. I'm going to start speaking a bit more about Stellar Health and our partnership, but I don't know if there's any questions. Garrett, I don't see anything in the chat, but is there another way that people are asking questions that we should pause for?
No, let's keep on moving. We'll have a dedicated Q&A at the end, and then we do have some questions rolling in, but we'll go ahead and do it that way.
Okay, great. Yeah, I'm sure there's going to be more for Dr. Schott than me, but we can do it at the end then. So before providing some detail on our partnership with St. Luke's, which Dr. Schott started to allude to quite a bit there, I wanted to provide a bit of a background on Stellar Health. Again, as Dr. Schott alluded to, and what we've typically seen and what our philosophy is that there's universal agreement that more healthcare spending should be focused on value-based and primary care. However, there's a fundamental incentive issue and lag between, action occurs at the point of care and rewarding to those that are meant to be engaging in that high value patient care, ultimately leading to, lack of activity happening at point of care, lack of engagement, less rewards, and then ultimately not the outcomes that we're all optimally looking for in value-based care. So our approach to the delayed incentive problem is really quite simple. We tackle this issue by meeting providers where they're at with technology and real-time incentives. So the philosophy is really to just have a lightweight solution that's in the workflow for all members of the care team, and rewarding each member of the care team for the time it takes to engage in high value care, such that all stakeholders can truly participate in the value chain. So that's the way we really do think about it, moving dollars down the value chain, right? Like St. Luke's is very good about creating a funds flow mechanism. We support them in making that more real time out to their network and all of those providers across the network, but really, with their support and our model, ensuring that, it's not payer holding up the dollars or aggregated clinically integrated network holding up the dollars, which often they don't want to. It's just finding a streamlined way to get that out that leads to those end of year outcomes and ultimately ROI for the payer, for the health system that's taking on those risk contracts. And ultimately, we are complementary to the current ecosystem of population health insights and EMRs. We're really focused on the 3 to 4 highest value activities that can be done for any patient and bring forward the reward to complete it, right? So, population health insights, amazing. Documentation, feet on the ground to support feedback and performance, nurses, things like that, all incredible infrastructure. Stellar is really just focused on the technological component and the reward component, enabling providers to do those things at the point of care or care teams when the patient's outside of the 4 walls, really as the primary care lever that fits into that ecosystem to drive end of year outcomes. What you see presented on this slide is our flywheel approach and how we collaborate with our payer and provider partners. So ultimately, by providing a lightweight solution with real-time actionable data, we can consistently understand, along with our partners, what is being acted on, what is not being acted on, what is being rewarded for, and where continued performance focus needs to be. And ultimately, as a company that completes payment administration and incentives for these activities that are being completed, what should be invested in? Where are you falling behind? Not waiting for a claims lag or an adjudication lag or a shared savings lag. Right now, this patient came in, these 3 things didn't happen. How should we be providing a performance feedback loop? And maybe we should be paying more for some of those activities as they take more time and they require more focus for this part of your network. Just a bit on our scale here, we have over 750,000 lives managed on the Stellar application, so actively managed across value-based care businesses, and we're active in 20 states with 50 plus programs. So I think I already used this metaphor before, the last piece of the puzzle, but we really do like to see it as this, especially as a technology company. There's so much excellent infrastructure out there that SINs, even payers, different health systems have created. We know squarely where we fit. And the way we fit into SLHP's network and value-based ecosystem is very consistent with how we think of our value add. The infrastructure out there that is people, technological, financial, we fit squarely in by driving focus at the point of care on those value-based activities and ensure that providers and care teams are rewarded for the time it takes to engage in high-value care. We've also found, which I'll expand upon further, that Stellar's really provided a qualitative value add in provider engagement and satisfaction, especially with non-employed affiliated groups. The real-time engagement and reward system we're giving providers is truly a unique experience, and we've seen SLHP take advantage of this by using Stellar to drive further engagement in core care delivery initiatives. So this is where we're at today in our partnership that was formed 2 years ago with St. Luke's, early on in our journey as a company, but ultimately just a great fit in what they were trying to accomplish and the way our solution works in this type of environment. We have deployed the platform across 1,900 providers, 250,000 lives now. This number is a bit stale, apologies. And 18 managed care plans, inclusive of all lines of business. So core to our model, and often what you'll see in value-based care might be a focus on, Medicare Advantage or ACO Reach, MSSP ACOs. We're really working with St. Luke's on all value-based care books of business, Medicare Advantage, ACA exchange, individual exchange, and small group products, large group. And then we're very proud of the support we provided to St. Luke's in launching a Medicaid value care organization for over 90,000 patients in partnership with the Idaho state government. Again, for the Stellar model, and then obviously in value-based care in general, it doesn't matter, necessarily what line of business you're on or what health plan you're with. It really is, patient is in front of me. There are high value things I can be doing for them to ultimately drive patient outcomes. What are those things? And then what Stellar is doing is bring those to the forefront, ensuring focus and rewarding for the time it takes to engage in those key primary care levers. The screenshot you see on the right here provides some insight on the provider experience on the platform. So every activity completed by a provider that is value-based, i.e. supports improving quality or reducing unnecessary costs or utilization, has a discrete reward associated with it. The SVU, which stands for the Stellar Value Unit, purposely a play on words for the RVU, to represent your value-based revenue ultimately versus your volume base. So practices have a consistent understanding of productivity across their users, medical assistants, care coordinators, providers, and what their total earnings will be at the end of the month, as Stellar supports monthly payments of value-based revenue. Beyond this impressive scale and strong value-based results achieved, what we're most excited about in this partnership is the provider experience. Simply put, providers are having fun and they're winning through increased revenue. Through St. Luke's commitment to investing in their network and further down the value chain, we're actively seeing improved performance and a greater total proportion of value delivered across the whole system. Something that's maybe a bit more fun here, but one of the main things that we track at Stellar qualitatively consistently is just provider quotes, provider feedback. Actually, for us, one of our main KPIs at our organization is providers asking for more of their patient panel to be included on the platform, which is what we consistently see, and further why we've had such strong engagement with SLHP's network as we're live across all managed care plans. Ultimately, having a simple and elegant experience and a transparency in earnings and value-based revenue brings that engagement forward, and is really, what we've still found 4 years into this as a company, still a unique technological and value-based experience for a lot of these providers. So this slide here, we wanted to lay out a bit what the provider experience is like in terms of payment administration, a service that Stellar provides for St. Luke's health partners and other health system and payer partners. Each month, each participating provider receives a co-branded letter and check, or ACH, automated clearinghouse, with a full detailed breakdown of what was completed in their practice and by whom. Practices can even bonus out individual medical assistants and other non-provider staff accordingly for their individual participation in value-based care. An inclusion in the value chain that Stellar and SLHP are very proud of, and we see medical assistants making as much as $200-300 additional revenue every single month for the type of work they're doing, that ultimately adds to the bottom line surplus seen across the population, but earned in real time by providers and then other non-provider clinical staff. We also provide a detailed accounting and bank audit statement of all payments made across the network as a financial responsibility and fiduciary responsibility to every client that we work with. I think finally, before we open it up for some questions here, and what we wanted to highlight per the subject of this webinar, and engaging affiliated providers through a unique technology and incentive model that we're working on St. Luke's with, is the effectiveness of the Stellar model and provider engagement in general. So each of these instances shown here are outcomes based on what we've seen resulting from our model, but all predicated on the fact that simply meeting providers where they're at and providing them with simple and streamlined solutions and transparency and expediency in value-based revenue goes a long way with relationship building. This is, we're not a network development team for any clinically integrated network, but simply through our relationships with providers in any given market, we've worked with ACOs through, recommendations on, ACO networks to join, adding 50+ providers year over year based on partnerships we might have through other practices and clinically integrated networks, and the experience they're having with Stellar through our payment system and engagement model. Even engaging providers at the individual practice level. When we worked with a payer and launching a P4P program, year one, 80+ provider groups reached greater than 4.5 stars, up from 2.3 stars average. It's not like these providers didn't care about their patients, previously weren't providing high quality care. They just didn't have necessarily the information or the real-time incentives to understand what they should be doing for their population and how they should be focusing their time. And ultimately, the rewards help them move towards that. And then what we have on the right here is our work with a large IPA that essentially advocated for Stellar to be their value-based solution for all their value-based contracts with a regional Blues plan, saying, we've seen, all of our providers are, across 40,000 lives, 450+ NPIs engage with Stellar in a way that drove performance on one book of business, immediately leading to them to want to work with us across all their payers. I'm gonna stop here and see and open it up for questions.
All right. Yeah, we do have some questions. A great presentation, guys. There's a lot here, and we do have a lot of questions to try to get through, and we've got some time to do that. So we should be able to hopefully to get at least all the ones that are in now. If you have a question, please go ahead and submit it, and then we'll get to as many as we can. First question here is for Dr. Schott, and I'll try to direct these as I can, but some of them you guys would know better than me who to answer that. Is what is St. Luke's percent of affiliates versus employed docs?
So, that's a great question. Over half of our, especially looking at our primary care docs, which is really the focus from a population health standpoint, over 50% are independent.
Okay. Next question is, how are you able to influence or manage LOS with your SNF partners?
That's a great question. Our PAC program has been really something, it was a clear priority for us going into 2017. We have a PAC manager, and what we've done is develop a close relationship with high-performing SNFs in our service area, where there's clear accountability. It started out with our joint and orthopedic providers, setting out some clear accountability on the SNF part to make sure that there were timely evaluations by providers when providers hit the SNF, holding them accountable to length of stay. We, looking at all of those metrics, develop a scorecard. Those scorecards are then shared with our discharge planners and coordinators on the health system side, on the inpatient side, in a way that really helps inform families and providers when they're planning a transition from an acute stay or inpatient stay to a SNF. That's something that consistently over the last 5 years, we're well above the highest benchmarks in terms of length of stay and utilization in general. But it's been a really, it's in my opinion, been a focused effort, really developing the relationship with those SNFs and then holding them accountable, as well as doing what we can to support the work that has to be done within those centers.
Great. We did actually get one question in here about the slides, and if you didn't catch the beginning, they will be available for download later on. Next question is, what are your plans for capitation, and to what extent do your payers delegate utilization review, pre-auths, et cetera?
It's a great question. The first part of that, in terms of just utilization in general, a lot of our work has been focused on keeping services in network. Within the health system, we can provide the majority of services, things like solid organ transplants, CAR T therapy. There are some areas where we recognize we have to work with payers to provide those services out of network. So the focus of our utilization management has been really working with payers to develop workflows so that we work with them in a collaborative fashion, recognizing many of our payers have preferred providers for those services. that they have external agreements with. But the focus has been, once the payer is aware of that service need, we work to make sure, number one, that we can't provide that service here locally. Number two, there's a review of the records to make sure that there's truly a medical need that supports that referral out. If that referral is out of network, as defined by our relationship with that payer, we make sure that the referring provider and the patient are aware of that out-of-network status prior to receiving that service. And alternatively, if it is something that we can provide in network, we make sure that we not only make the patient and referring provider aware of that, but also facilitate getting that patient in a timely fashion to the network provider. I'm not sure that I capture all the questions. I think there were kind of two parts to that question.
Yeah, the next part had to do with, I guess, with payers and like pre-auths.
Yeah, the pre-auth, in my opinion, as a provider, pre-auths, we need to get away from the majority of the prior auths, as many as possible. And so that's been a focus for us over the last 6 months, especially. The prior auths, we don't, prior auths sit within the realm of our payer partners. And so really the only impact that we have is that out of network referral management process. The prior auths currently are all dependent on our payers at this point.
Okay. And we've got questions that keep rolling in, so we'll keep moving through them. This one is, do you have risk-based contracts with SNFs and or HHAs?
No, we don't currently.
Okay. Let's see. Next question is, how has St. Luke's measured patient satisfaction with respect to using the Stellar provider incentive platform?
Daniel, you correct me if I'm wrong. I don't think we've worked with Stellar on any kind of patient satisfaction specific to Stellar. Patient satisfaction, patient engagement is a clear priority of the health system. But I don't think it's been anything that we've collected data on specifically with Stellar, but correct me if I'm wrong, Daniel.
Yeah, no, that is something that is in development with us. We've launched it with some other partners, and we will be launching with St. Luke's soon. They've been great partners in kind of advancing our approach to it, but the Stellar approach and you know what we're co-developing as it pertains to the St. Luke's population is still focused on technology and rewards, right? We're surfacing information at the point of care and rewarding for the time it takes. You know, so for us, it really is those, when we talk about patient experience, you know, ultimately better care equals better patient experience. But, you know, from, you know, those survey measures are becoming more and more important for Medicare Advantage. So what we're doing is we are listing out like the key survey questions as it pertains to patient experience as kind of like a patient survey to be handled at the beginning or end of an annual wellness visit, really. And however many of them are covered with the patient at the point of care by the provider, they literally, you know, Stellar's a value-based checklist. They check off what they cover and they earn rewards for it, right? So if it's understanding, you know, their access to a specialist, that will be something that's discussed. They mark that off in Stellar and they earn their value-based revenue accordingly. And then what we're starting to further develop to supplement it is educational resources. So, you know, you can, if it's something like even as simple as physical activity based on the patient demo, there might be a printing of like the recommendations for the patient demographic. And then, hey, take this on your way out, this pamphlet or this one pager on what are the appropriate physical activity recommendations for you as a, you know, 67-year-old male who might be overweight, for example. So those are the types of things we're innovating on. And then from a Stellar perspective, because we're, you know, measuring activity engagement, you know, we can reward for each step of that process for, you know, checking off that you've covered it with the patient, even printing it, mailing it to the patient, getting a feedback loop from the patient on their experience. So there's a few different areas we've explored, and these are the things that we have out in the market and what we're working with St. Luke's on.
And Garrett, just to jump in there a little bit, I think it's a question that health partners frequently gets, not so much from payers, but especially from large groups that we may have discussions with. Board members ask, what is going to look different if I'm a health partners member? Mm-hmm. And the work that Daniel described, if you think about it, overall, we're driving towards a care model that is proactive rather than reactive. And so I have had subjective comments, both from patients and providers, that at its core, having information that they can act on so that there's proactive outreach that facilitates getting patients in for an annual wellness visit. And that's something that's strategized. The lists that we share through Stellar rank patients based on an illness burden. So again, back to that whole issue of access, providers frequently ask me, like, who do you want me to focus on first? The information that Stellar helps us collect and share gives those patients in a ranked, strategized kind of priority, so providers and clinics can easily see who is their sickest and who they need to focus on. And so to the question, both providers and patients have experienced and stated that they've noticed a difference in how the care experience has been impacted, because it really does facilitate that proactive approach.
Got it. Well, everybody stay tuned. There may be a part 2 to this in several months as we redress it. Okay, next question is, what criteria and how do you quantify the value of rewards per provider, and to what extent are the providers involved in determining the value?
Dr. Schott, I'll look to you. I can describe our partnership aspect of it and how Stellar supports that value aspect, but obviously you do a lot of work in valuing these types of things for your network. So maybe I'll let you answer that first, and then I'll dig into our partnership on it.
Yeah, I think it touches on really the importance of the partnership in terms of implementation and even ongoing work. For example, we just finished work with Stellar on scheduling annual wellness visits. And so we have the flexibility within our partnership to say within a given geographic area or group, we want to incentivize slightly different work because we see an opportunity to make improvement. Annual wellness visits was our first kind of campaign. And so there was additional financial incentives through SBUs for those clinics that really focused on getting patients scheduled. The next round of that is how many of those annual wellness visits are actually completed. And so I think, and Daniel, you can speak to this more, but I think that one of the standout items has been the partnership has been flexible, both in terms of how Stellar works with us, how the platform was implemented, and also down to the level of what we felt like we needed to incentivize and how that needs to change over a period of time based on the performance that we reflect. Daniel, I'll pass it back to you.
Yeah, no, that's great context. And I think, the simple answer is that any risk-bearing entity we work with, whether it's a clinically integrated network like St. Luke's or a payer or an ACO, it's their decision, right? They have the understanding of what they want completed at the point of care and the value of it and the type of ROI and improvement in patient outcomes they're going to achieve. And they feed that through Stellar in a completely customizable and flexible way. That's the short answer. A bit of a longer answer is that for us, the sniff test ultimately of what we put in Stellar, as long as it's tied to a value-based outcome of improving quality or reducing unnecessary cost or utilization, we're going to feed it through Stellar and incentivize it at the point of care and for the care team. So ultimately what we're doing with any one of our partners and what we do with St. Luke's is we're developing, I kind of hit on the concept of the SVU before, the Stellar Value Unit. We're creating a fee schedule, but it's a fee for value schedule. These are the different activities: scheduling annual wellness visits, completing annual wellness visits, reviewing chronic conditions, transitions of care, quality screenings, medication adherence, all of the core activities that we're focused on. And then ultimately what we're determining with them is what are the priorities in the network to drive patient outcomes and drive that surplus that you're looking to get on your value-based contracts. And then how much should we be paying for each item so that every single thing done has a discrete ROI associated with it. And again, ROI, we're talking about patient care here, so I don't want to be too finance focused, but the beauty of the ROI and these value-based care contracts is that it's tied to a value-based outcome. So ultimately we're focused on the highest patient impact. And then to Dr. Schott's point, this isn't a static schedule, right? We're not saying, okay, here's the Stellar SLHP, fee for value schedule for 2022. This is what you can earn. We can make that completely flexible and dynamic over the course of the year based on priorities, right? Like something we do with St. Luke's and a lot of payer partners is we'll just pay more for annual wellness visits in the first 6 months of the year for scheduling and completing them, just because it's higher value to ensure it gets done in the first 6 months of the year. Other things we do, and this kind of, some words I haven't used in this presentation, but for those of you who have studied this or read literature on this, probably understand that what we're focused on is behavioral economics and why we're so effective. And ultimately, some behavioral economic approaches that we engage in are things called like surges. What we'll do, so it can be breast cancer screening awareness month, and we'll say, hey, usually pay $30 for the completion of a breast cancer screening or mammogram. We're going to pay $60 for this month, and it's going to drive more engagement and get more of those patients in to complete those screenings. And then we might bring them back down because there was a hyper focus on that, and then we'll surge elsewhere, for example. Some other approaches we take is the concept of team-based incentives. What we call them is a practice challenge, and this can be customized to a part of the network. Again, this is all coordinated and collaborated on with people like Dr. Schott, clinical professionals and population health professionals. And we'll say, hey, this part of the network is they're just lagging in annual wellness visits. We're not getting engagement there. Why don't we create a team-based challenge where if they schedule, let's say 20 AWVs, they're going to get an extra $100 reward, right? Not a cumbersome amount, but something that creates that engagement model and a way for them to hit a milestone to earn more of that value-based revenue, and a tangible target, not an end of year 18-month surplus, something that they can work towards now and earn now. Yeah, those are the types of approaches we work on. But I think, again, the short answer is it's not Stellar's decision. We're an enablement of the goals of our health system and payer partners.
And just to follow on that quickly, team-based care is obviously a key concept. I think within an organization as large as the health system, how to transform care into something that's team-based is really difficult. Going back to my days in Oregon, as a provider, we struggled at that time. I was in a small independent clinic, 12 providers. We were doing well in terms of our quality performance, but it was completely dependent on our team members. We had everyone from the front office to the back office. It was really facilitating and doing a lot of the work that Daniel shared within the context of Stellar. What we couldn't figure out was how to financially pass that on to our team members in something that was really structured. As this rolled out over the last year and a half within the health system, I'm currently 1 day a week in clinic. It's hard for me to describe the level of excitement in those clinics as Stellar hit them, because our MAs and our front office personnel, they were able to contribute to the care of patients in a completely different way. It was something that was objective. They could see the results, and they felt like they were participating in patient care. And the finance stuff aside, the impact that it has to actually building momentum in a way that helps support team-based care can't be overstated.
Great. All right, next question, and this is for both of you. What sort of buy-in do you see from the health plans in this space, and is it easy to get them on board to move to a Stellar type model, or do you still see resistance and a desire to hold on to fee-for-service?
I'll go first, Daniel, and you can clean up. As I said earlier, our entire business model was something, we had no prospective payment from payers. And I think going back to that question earlier, Garrett, it was on whether or not we're looking at capitation. I think capitation has to be there. It's, I think, from a primary care perspective, where we need to go. The question is, how do we work with payers to do that? Stellar was something that helped us start the conversation with payers. We had 2 or 3 payers that were pretty quick to support the work. Currently, I think all the payers that we work with are on board. And so there's not been resistance. And I think that largely that's because the results speak for themselves. And so currently here with health partners, payers have been widely accepted.
Yeah, I honestly don't have much to add there. That's an excellent answer. But the only thing that I'll say that we've seen elsewhere is, in addition to St. Luke's, is payers often try to, or they do develop their own incentive programs like this that have the same lag to it. It's a P for P or a QIP or whatever it may be called, and it has that same lack of engagement that might exist. That they're seeing in a value-based contract, even if they delegated the risk, there might be some results that they're not happy with. So having the confidence that any money fronted to fund a stellar program is going directly for the completion of activities that are going to drive value for the payer and the provider is often very well welcomed. I don't want to speak too out of bounds here on the concept of care coordination fees, which are really important from an infrastructure perspective for a lot of health systems, but I think the concept of funding that into a bit of a black box for payers versus I'm funding this, but I know it's going directly to the completion of high value activities by providers for patients is really welcomed from an investment perspective.
I agree, and I think the other thing you touched on there, Daniel, is uniformity. We have providers in the network who have independent value-based relationships with payers, and they provide those providers with their own set of information and different platforms to do this work. I think that from a network perspective, we can't expect our providers to perform to different sets of metrics, use different platforms across the board for all the payers that we're working with. We've really got, in my opinion, we've got to get to the point where there's a clear focus and some efficiency within the clinics in terms of how operationally it's implemented. And Stellar, for the network, has been able to give us that platform.
Great. We have time for maybe one or two short questions, and then we'll have to wrap up, unfortunately. Next question is, what % of your clients realize sufficient shared savings or bonuses to recoup the proactive payments prior to the client receiving funds from the payer?
So that's a stellar health question. And let me just make sure I hear that, Garrett, prior to them receiving.
I'll read it again here. What % of your clients realize sufficient shared savings or bonuses to recoup the proactive payments prior to the client receiving funds from the payer?
Got it. So I think the key there is the fact that they are going to recoup any upfront investment, obviously in Stellar Health as a partner, but more so the upfront investment they're making in their own network. Right. So this is the concept of moving dollars down the value chain, whether it's an SVUs or a fronting of the shared savings they're going to achieve, which is what you've described here. I can let Dr. Schott speak to their experience. I don't want to talk about the St. Luke's. They can speak to their own results better. But what we found is all of our partners. It's why we have been able to grow so quickly as a relatively young company in the market. It's just a simple model that works. You invest now in high ROI activities that will lead to outcomes on the other side, and they come, right? Like if ultimately you understand that paying for this screening to happen now will lead to getting to 4 stars, properly capturing illness burden, reducing unnecessary utilization through transitions of care and enrollment in risk stratification and care management programs. 18 months, you're going to realize that at a 5, 6, 7x ROI, which comes in that surplus check. So ultimately, a PMPM funding up front directly for activities as opposed to, hiring more individuals or, putting in more, for infrastructure that might be very costly has been pretty consistently realized for us. But I'll let Dr. Schott speak to their experience.
And if I understand the question, from a network perspective, we treat the investment in Stellar as medical spend. And so there's nothing that, for example, within our funds flow, the money is not coming out of our pool at the end of the year to support Stellar. It's just medical spend from that context. And if we're thinking about it correctly, a lot of this gets down from a clinician point of view. How do we get those patients in for their annual wellness visits, to get their care gaps identified, to make sure that there are care plans in place for those conditions, If we do that and we drive down emergency room utilization and admissions, then those are the main drivers in terms of what we have to act on from a risk standpoint. And so we, at least over the last 2 years, again, our funds flow for this year is just in process. Our providers see this there's no risk in this. The more effective they are in using Stellar, that's money up front to support their work. In the long run, if we're effective at decreasing that utilization and decreasing the variability, that gives them kind of a double bonus.
Okay, we have time for one last question, and if we could keep this one pretty quick, because I think you could probably go into it just for the interest of time, but this is a fun one, so I want to make sure to ask it. What 3 particular VBC initiatives have resulted in the best ROI?
That's a great question. I think for us historically, PAC has been, and largely that's just because of the scorecard development relationship that we have with SNFs. I think largely our focus on annual wellness visits, rolling that out. Those would be number 1 and number 2. I can't think of a third one off the top of my head.
Yeah, I can round it out in the interest of time, so not to go through all 3. Also, not a clinician like Dr. Schott. I'm going to speak to it more from the Stellar experience, but yeah, I'm just doubling down on annual wellness visits. I think there's a lot of studies out there that show just like getting those done, obviously, focused on the higher risk patient first, but getting those done, closing gaps of care, like the ultimate improvement in cost reduction is just such a clear association there. And then obviously, as Dr. Schott has spoke about the SNF program, I've previously worked in some SNF care and efforts and seen how effective those things can be. But I think the third one to round it out, and this is in Stellar's view, and again, something we're in the process of co-developing as a new program with St. Luke's, but something that we do is like a true enablement solution and not just being kind of like pop health analytics, is the concept of enrollment. So for us, so many, there's so much sophisticated like development of like interventions out there, but they're not necessarily being acted on or happening, right? Like care management programs, remote patient monitoring, congestive heart failure, diabetes specific management programs. St. Luke's is an excellent care management program, and the biggest issue that they have, and we've seen elsewhere, and correct me if I'm wrong, Dr. Schott, is just getting the right patients into them. And what we do at Stellar is previously, no more effective way to get a patient into a type of validated program or value-based service than having their primary care team talk to them about it. Truly as the quarterback of care, giving them, again, the information. Like often we've seen primary care providers might not even know that these programs exist or that patients should be in them. And then again, they didn't have an incentive up front, right? Like inherently, maybe they understand that if they get, a surplus check at the end of the year, this could contribute to it. But right there, when the patient's in front of them saying, hey, we'll pay you $25 just to have the right conversation with them and ensure they enroll in this program that they're eligible for, that, St. Luke's or another partner has told us has a 5 to 6 to 1 ROI. And then, obviously more focused on improving that patient's experience and outcomes is something that we do consistently and something we've seen really, really strong results on. And for me, it's, as a patient, honestly, it's really cool because I've had so many times, I'm pretty lucky with my health status, but I'd love to just be told what else I could be eligible for and what other care I could be receiving that would be, fitted to me. So the fact that we're able to support St. Luke's and delivering that is something we're proud of, and we've seen a lot of results for.
Great. Well, I hate to cut off the discussion, but unfortunately, that's all the time we have for today. Thank you guys so much for the presentation. It was wonderful. There's a lot there. If I could have you go to the next slide here in conclusion. Items for discussion. There we go. I wanted to encourage everyone to, if you want to learn more about Stellar Health, stop by the booth, the exhibit booth. There's a virtual exhibit hall that you can go to at BBC Exhibit Hall, and you can go to the Stellar booth and learn more about them, interact with their team, and see what some of the resources they have. And there's a lot there, so I encourage you to please do that. And there's a link in the slides if you download them later. And then finally, I wanted to thank you all again for attending today. I know there's a lot going on right now that's kind of competing for your attention. So we really appreciate you coming today. If you wanted to get in touch with either of our speakers today, please, their emails, can you go to the final slide there, Daniel? Oh, there we go. Okay, it's on the question slide. So yeah, their emails are here, their contact information. So if you want to reach out to them or to me, I'm happy to put you in touch. So thank you all again so much for coming, and I hope you have a wonderful rest of your day. Bye-bye.
Thank you very much.